bit. Welcome to everyone who's here in person and those who are joining us on the Zoom webinar to Grand Rounds. We're really pleased that you're joining us today. We have a great session scheduled. A few announcements before we get going. I'm Jeff Miller. I'm one of the co-directors of Grand Rounds with Kate Elkington and Christine Denny. I want to let you know about next week's Grand Rounds, which will be a fully remote session. It is part of the Addressing Structural Racism series organized by the Office of Equity, Diversity, and Inclusion. Next week's speaker will be Paula Braverman, who is a professor of family and community medicine and the founding director of the Center for Health Equity at UCSF. And the title of the talk next week will be Systemic and Structural Racism. Okay, and then just a few notes about today for the Zoom webinar attendees. I want to encourage you to ask questions at any point during the talk. And to do so, please post your question in the Q&A function at the bottom of your screen, not in the chat. And if you're a trainee, we will try to prioritize trainee questions. So please put the word trainee in your question. And then lastly, we would encourage you to ask your question yourself if you're attending via Zoom. We can promote you to a panelist temporarily to ask your question. And so if you do post a question in the Q&A, please write in as part of your question, can ask question myself or prefer to have question read. Okay, great. So today's Grand Rounds is part of our Clinical Updates in Psychiatry series. It's a little bit of a shift from our usual Grand Rounds. The goal is to have local experts in a topic area relevant to the practice of psychiatry do sort of a CME style update for our ability to help us implement best practices in a clinical area. And so we're really lucky and thrilled to have two experts today in DBT, Dr. Zachary Blumkin and Dr. Beth Brodsky. I'm going to introduce both of them now, and then they will each give part of the talk today. So first, Dr. Zachary Blumkin is an assistant professor of medical psychology and psychiatry at Columbia. Since September of 2022, he's been the clinical director of our faculty practice organization here. And before that, he was clinical director of the Columbia Day program for 4 years previously. He's also been a course director of a course to psychology interns and psychiatry fellows on empirically supported psychotherapy techniques, and has provided supervision to trainees in CBT, DBT, evidence-based treatments for disruptive behavior disorders as well. He specialized in working with children, adolescents, young adults, and adults. In addition to individual and group therapy, Dr. Blumkin works with families, parents, and couples, and he provides evidence-based treatments. He's Linehan board certified in dialectical behavior therapy. Dr. Blumkin completed his clinical internship and postdoctoral fellowship at Children's Hospital here at Columbia. And then after Dr. Blumkin speaks, he'll pass the baton and microphone over to Dr. Brodsky. So I'll tell you a little bit about Dr. Brodsky as well. Beth Brodsky is an associate clinical professor of medical psychology in psychiatry here at Columbia, and she's also the associate director of the Suicide Prevention, Training, Implementation, and Evaluation Program at the Center for Practice Innovations here at NISP. Her areas of expertise include research and psychotherapeutic treatment of self-destructive behavior in borderline personality disorder. She's published numerous articles and chapters on the topics of suicidal risk and treatment of suicidal behavior in borderline personality disorder. She develops online learning modules and webinars to disseminate best practice prevention practices among mental health practitioners across New York State. And I will just editorialize very briefly by saying that anyone who is affiliated with an OMH institution like NISP has access to the videos that the educational videos that Dr. Brodsky and her team have produced. And so maybe we can talk about how we can access those if you're interested during the discussion section. She's trained in DBT and teaches DBT and other evidence-based practices for suicide prevention to psychiatry residents and psychology trainees. And I will just, again, editorialize by saying that she is a beloved teacher and supervisor of psychiatry residents here in DBT. And so we're really lucky that she's extending that training to our whole department today. And she has a private practice in Manhattan. Okay, so on to today's talk. The title of the talk is Keeping Calm and Carrying On, the DBT Approach to Managing Suicidal and Other Difficult Behaviors. Thank you, Zach, for getting us started.
All right. Thanks everybody so much for coming, both online and in person, and to Jeff for that really kind introduction. And Beth, super excited and honored to co-present with you today. So I'm going to try to get us through this first section nice and easy, where we're going to describe the basic DBT interventions and understand the DBT strategies for reducing emotional, behavioral, and interpersonal dysregulation, as well as understand how the therapeutic approach enhances not only the treatment that's being provided by the provider for the patient, but for the provider as well. And we're going to use some clinical examples today, and just want to highlight that these are many different experiences that we've had with different patients, and all information is de-identified. So we're going to split it up into two sections. The first part is going to be the overview of the DBT skills and strategies. The second part is going to be more of the theoretical kind of underpinnings of DBT. With that, we're really going to focus on that first stage 1 section of DBT, meaning when that house is on fire, that basement is on fire, we need to get folks out as quickly as possible. There's a lot of behavioral discontrol, usually manifested in sort of non-suicidal self-injury or suicidal behaviors. And that's where we're going to really focus. Oh, I got it. All right. So this is probably my favorite quote on DBT, and I just love how it makes it so simple. It's so easy. All we need to do is be really, really validating towards patients who are very dysregulated, and we need to make sure we never blame. On top of that, we need to block all bad behaviors, then drag out good behaviors, and then figure out a way to make the good behaviors so reinforcing that the patient continues the good ones and stops the bad ones. Super easy, super, just straightforward. And to me, this is an example of a dialectic, which I'll talk about in just one second, in that in some ways it actually is really straightforward, and in other ways it's really, really challenging to do this. And so examples of blocking bad behaviors, I work a lot with teens, and so non-suicidal self-injury, suicidal ideation, suicidal behaviors, not engaging in treatment. For those of you on Zoom calls, I don't know if you've seen this a lot. I see the tops of the heads of a lot of teens early on in therapy because their head is down. They don't want to engage in it, right? A lot of avoiding social situations or avoiding academics, maybe some school refusal behaviors. We're trying to block these behaviors and drag out in DBT mindfulness to emotions, mindfulness to their thoughts, mindfulness to the consequences of engaging in therapy, as well as the skill use, which is so important. And so dialectics, let's talk about this. Dialectics are when two opposites come together to form a larger truth. And the real take home I want on this is when you think about dialectics, people are like, okay, so you have black and white and you combine them, and now you have something that's black and white. The truth is you have something that's black and white and you combine them and it forms an entirely new truth. So actually it comes together and forms gray. The middle way of the half point between two extremes is a completely new path. I'm going to give you a silly example, but I recommend using this with your patients in person or via Zoom. You have ketchup. What color is ketchup? Folks out there in person, what color is ketchup? Red. Nice. And then you have mayonnaise. What color is that? White. All right. Opposites in some ways. Ketchup is sweet. Mayonnaise is, tangy. Ketchup is slimy. Mayonnaise is gloopy. So we could see they're opposites in some way. When you combine them, though, you don't say, oh, look, it's ketchup and mayonnaise in a bowl. We say it's Russian dressing. That's the idea behind dialectics. It forms an entirely new idea. And that's what we want to be focusing on in our treatments. And I should say this, when we're dialectical, we can expand the way that we think about things in a different way. We can unstick some of the standoffs we have, and we can be a little bit more flexible. Who benefits from DBT? So you'll notice that this bullet point that we put together highlights a lot of the different criteria within borderline personality disorder. But the truth is you can break some of these up and see these in other areas of psychiatric issues that your teens, your young adults, your adults present with. The one piece I really just want to highlight on today is the significant emotion dysregulation. A lot of the referrals that I'm sure Beth gets and I get are for folks who are very severely emotionally dysregulated in an externalizing way, in what we call an underregulated way. They're screaming, they're yelling, they're breaking, maybe they're engaging in self-harm or suicidal behaviors. But there's also the overregulation, and we see this as well. And these are folks who are pulling away, shutting down, withdrawing, avoiding, covers over the head in a very extreme way. And both of these are forms of dysregulation. And the overregulated folks, they tend to be missed because sometimes overregulated folks don't do as much damage as folks who are underregulated. So something to think about. All right, there's a lot of evidence to support DBT. This is sort of hot off the press from a conference that happens every year. It's called Is It DBT? It happens on the eve of ABCT. I highly recommend it, or the day before ABCT, if folks are interested. And there they talked about how we currently have 60 randomized controlled trials for DBT, which is really exciting. Many of these randomized controlled trials demonstrate a reduction of suicidal behaviors, a reduction of self-injury, reduction of symptoms of depression, hopelessness, anger, impulsivity, a reduction of hospitalizations, as well as an increase in overall social adjustment and positive self-esteem. Now, I want to kind of break this up very quickly, but the piece I want to say first is that out of those 60 randomized controlled trials, 31 of them were comprehensive DBT. And I'll talk about what comprehensive DBT looks like. 26 were DBT skills primarily, and then 3 were adapted DBT. And I'd love to get to talk about that. Hopefully we'll do that at some point as well. And then the other thing that I want to bring up is, and we talked a lot about this in the conference this year at Is It DBT, was thinking about ethno-racial minority inclusion rates in these studies. So there was a wide range in the 60 different studies where it ranged from about 5% representation to anywhere to 85%, with half of the studies making up of less than 30% of an ethno-racial minority group, which is a problem. Additionally, I do want to say this, that sexual minority groups were well represented in most of the RCTs, which is really interesting to think about. So kind of what's the take home with this, at least in my opinion, is that there's evidence that we can use DBT with some ethno-racial and sexual minority groups in clinical practice based on the outcomes of these studies, including dropout rates, which I think is really important. And we as DBT researchers need to do better. There needs to be a way to ensure that our studies represent minority groups in a more adequate manner, right? In a more whole manner. So go beyond just that representation to conduct studies with large absolute numbers of minority participants, to assess and report what other minority identities that haven't been hit on, like maybe gender identity in some of these studies, that needs to occur. And we need larger sample sizes of folks within minority groups or minoritized groups so that we can look at some of the intersectionality between folks who might be in multiple minoritized groups. And I think that's something that's really important. The last thing I'll say is making sure that when we're doing these studies, we're comparing the outcomes of minoritized groups to non-minoritized groups. And I think that's sort of a sign that DBT has a ways to go with that. So what's the overarching goal in DBT? Build a life worth living. A life worth living has both positive and negative aspects, happiness, sadness, and anger, and all of these aspects are necessary and valuable. This is sort of step one that we're doing in our sessions. We're introducing folks to life worth living. I texted a bunch of my close colleagues in DBT last night, and I said, you know what, I want to put some of your life worth living goals that you've seen recently with some of the patients you're working with, both teens and young adults and adults. I got a lot of inappropriate responses, so I'm not going to include those, but I will include some of these, like, I want to move out of my parents' apartment. And by the way, this is from clinicians who are reporting on behalf of their patients. I want to graduate from college. I want to live my life as a girl. I want to move to London and live with my friends. Sounds nice. I want to go to school and do activities without being completely overwhelmed by my emotions. This is an example of somebody who was overregulated. I want to open a doggy daycare shelter. We're constantly bringing our patients back to this life worth living. These are folks who are severely emotionally dysregulated. We're trying to get them to use those skills. We're dragging those good skills out, and we're blocking the ineffective behaviors, and we're tying it back to their life worth living. The central dialectic in DBT is extremely important. This is the idea that it's a constant dance between acceptance and change, right? And so this is something that the folks that I work with hear over and over again. And by probably, I don't know, week 5 or 6, they're like, I know what you're going to say. I know what you're going to say. We're doing the best that we can, and we need to do better. And I want us to think about this from a dialectical perspective. If I'm working with somebody who's really struggling to use skills, but they've committed to engaging in DBT, we've worked hard to get them to a place where they say, fine, I'll try the skills. Fine, I'll do the group. I don't want to do it, and I'll still do it with you, Zach. I'll say, great, let's do this. If I were to say, listen, you're doing the best you can, but you need to try harder, that but negates the first half, and that's all they're going to hear. So if we connect it in a dialectical manner with and, now they hear, hey, you're doing the best that you can, and I need you to focus on distress tolerance just a little bit more this week. That can be really helpful, and the way that we really think about the treatment. So you can't really talk about DBT without talking about the biosocial theory. And I'll just do kind of a quick and dirty example of what this looks like. But this is how we understand chronic emotional dysregulation in folks who are receiving DBT. And we work hard to understand somebody's narrative through this model and really help them understand what this model looks like. In fact, if they're doing DBT, they're going to review this model 4 different times in their skills group. So the model. 2 sets, biological vulnerability and an invalidating environment. The biological vulnerability looks like folks who are just born, hardwired to be a little bit more sensitive. It's as if I had a patient actually say this to me. It's as if the emotions are molecules in the air and I can see them and no one else can see them, right? If I had a burn on my arm and nobody else had a burn and you open the door, the breeze from that door opening could hit my burn and I would feel it, but nobody else would notice it. This is the sensitivity that we're talking about. Reactivity is something that we also talk about. Instead of going from 0 to 60, folks will go from 0 to 120 like that. It'll happen very quickly. And by the way, remember, it doesn't always go up where you're going 0 to 120 and you're getting upset and angry. Sometimes you shut down. We're not talking about a little bit down, a little bit sad. We're talking about despondent, catatonic, not engaging, fully upset. And then there's slow return to baseline. So somebody struggles to get back to their baseline, back to that regulation. And if you think about it, reactivity and sensitivities are like logs on a fire. Every time we try to come back down, somebody says something and I go back up. Somebody says something and I go back up because I'm feeling a little bit more sensitive and a little bit more reactive. So you have an individual with these biological vulnerabilities, and then you have an environment that's saying, what you're thinking is wrong. You shouldn't do it that way. You shouldn't feel that way. It doesn't make any sense. When these 2 things combined, or we say in DBT, it leads to this multiple problems or chronic emotion dysregulation. And I want to give you an example of a case that I've seen where the teen said to their parents, I have a stomach ache. I really can't go to school. I don't feel well. This is a teen who has a history of anxiety, maybe a teen who gets good grades. And so what does the environment say? Oh, it's just a stomach ache. You'll be fine. Have a piece of toast. So it goes back to the invalidating environment. What does the teen say? No, it's not just a stomach ache. It really hurts. I really can't go to school. I don't think I'll be able to take the test today. Can I please stay home? Stop doing this. You always do this in the morning. We got to get to school. I'm late. I have a million things at work. I have to do grand rounds at Columbia today. Please don't bring this up right now. Teen doesn't feel heard, gets more dysregulated, upset, maybe goes in the room, slams the door, goes under their covers, right? It transacts and feeds off of each other and reinforces. So what do we try to do with families, with teens, with adults to break this pattern is we teach validation. Validation is such an important skill. There's a research study that was done just a few years ago by Jill Rathis. Alec Miller, I think, was on it, and a couple other folks, where they talked about the treatment acceptability of walking the middle path. And that's one of the modules in DBT. And parents and teens rated validation as the most helpful skill out of all the skills. And so if you want to know where I start, session 1, basically first sentence is validation. I'm jumping right in a very radically genuine way, which means I need to find a way to validate and truly understand where that person is coming from, even if I don't agree with it. And so when we invalidate somebody, we see an arousal in a physiological manner, in a sense of feeling out of control. When we're out of control, when we're aroused, our ability to process new information, new learning, use skills goes down the tubes. It's not going to work. But when we can validate somebody and communicate to them that we understand where they're coming from, they're less aroused. They feel heard. They feel more ready to hear skills and talk about the next steps. And I'm going to give you an example of, I'm guessing, when most of you have been validated. So I'm imagining everybody in Zoom land and here today, you've called either an insurance company, an airline, or maybe your cable company. And you call them up and the first person gets on the phone and says, nope, can't help you. I don't know. It must be an issue with your home. I would check the power of your router. I can't help you. Nothing I can do for you. What happens? We feel invalidated. We get dysregulated. And what is the magic word that we somehow all figure out, or the phrase that we figured out in our 20s? It like comes to us in our 20s. What is the phrase? What do we say? Can I speak with your supervisor? Supervisor gets on the call. What's the first thing the supervisor says? I'm so sorry you went through this. This sounds so difficult. I'll look into what's going on with that person. That they should not have said that. Let me help you. We're validated. Our dysregulation goes down. We're more apt to accept how they're going to help us, in what ways they're going to help us. So validation is a key in everything that we do in DBT. Radical acceptance is also a really important part of what we're doing in DBT. Radical acceptance is the idea that we're radically, completely and totally accepting reality for what it is, regardless if we don't like it. And a phrase that we use in DBT is radical acceptance helps us turn suffering you can't cope with into pain you can cope with. All right, I'll give you a very quick example. If you don't radically accept that somebody was nominated into a political position that you don't want them to be in, and they got the nomination, they're going to start their term in just a few years, and you say, nope, they're not my person, they're not this, they're not that, and you don't accept it, there's nothing that you can do to fight it, to combat it, because you're not accepting that they're in that position. But if you accept that they were nominated, they accepted the position, they're moving into it, well, now you can advocate. Now you can volunteer. Now you can kind of think of different ways to maybe move away from that suffering and learn to cope with it. And that's why acceptance is so important. So many DBT skills focus on changing behaviors in order to change the situation. But there are some times when there's no way to change the situation. And that's when we use radical acceptance. Picking on the airlines again, right? I don't know if anybody flew Southwest. I think it was last week or the week before. Sometimes you need to just radically accept that your flight is canceled and there will be no more flights with that airline for 4 or 5 days. Until you accept that, we will not be able to move on to change. I'm picking on Spectrum for those New York City residents. Sometimes you just need to accept that you are in a commitment with Spectrum for the next 12 months, and they are going to help you to the ability that they can. But a very much more serious example is COVID. Right? We need to accept that even in January of 2023, if we can believe it, that most people in this room are wearing masks, and that folks are still going to get COVID and miss out on important events like holidays, birthdays, graduations. That's still happening. We need to accept that. And until we accept that, we won't be able to learn to cope with it. All right. So what happens in DBT? So when you look at the slide, I think one of the main take homes is without these 4 components, individual therapy, telephone consultation, consultation team, and skills training, it's not comprehensive DBT. And something else that came out of the conference that happened in November, which is, again, just going to put another plug into attending Is It DBT, is they looked at kind of what is the minimal or the lowest level of intervention or intensity with expertise and resources needed to achieve a clinically significant improvement for a specific outcome, for a specific target population under a set of conditions. So basically what we're saying is, how can we downsize DBT and make sure that it still works? And a really great study came out this last year in 2022, which compared folks who did DBT for 6 months and folks who did DBT for 12 months. And what they found out is the 6 months was comparable to the 12-month rotation, which is really good news. And these were still high-risk folks who met criteria for borderline personality disorder. They also looked at a major study that I think had about 19,000 participants. It was published in JAMA, where they gave folks an online skills training. And then the electronic medical records sent them reminders about skills to use. And in this study, what they found is, unfortunately, offering this increased the risk of self-harm among at-risk adults. So that's too low. That's not enough, and obviously not helping in any way. It's making it worse. So we're still working on ways to find how we can make DBT accessible for everyone. And when I think about that, it's not only patients, but it's also providers who put in the time, it's clinics and programs that may not have all of those resources. But regardless, this is what it looks like. Individual therapy, we're focused on goals, reducing those ineffective behaviors and replacing them with effective behaviors through skill use, improving relationships. Telephone consultation is a part of DBT. And I'll tell you this, somebody who does telephone consultation 24 hours a day, 7 days a week, I love it. And the reason why I love it is if I get a call from a patient who's really struggling and wants to engage in self-harm, and I can help them use skills, and they use skills and don't use self-harm, that reinforces itself. Now they've used a skill that was effective, and next time they're not going to call me, they're just going to use the skill. And now we've significantly reduced the chances that they're going to engage in self-harm. So the ability to engage in that real world moment when they're severely emotionally dysregulated is really, really helpful. Consultation team is a must. Being able to receive supervision, but also support, making sure that we're staying the course or being effective, super important, and managing our stress, because sometimes these cases can be high stress cases. And then skills training, it's weekly, it goes for 6 months. We're working on practical skills, working on all the modules. In many places, or I should say some places, you'll have 2 therapists and around 6 to 10 patients or 4 to 5 families. So what happens in individual DBT? Well, we have the diary card. The diary card is super important because it gives us really concrete information on what occurred over the week. I can see the emotions, I can see the behaviors, I can see the skill use, the skills that weren't used, I can see any ineffective behaviors that occurred. So it's so important. Early on in that treatment, you are understanding that the patient will do the diary card, the patient understands they're going to do it as well, and it's reinforced every single time, so we're getting that information. We're also going to set an agenda, and I'll talk about that in 1 second. In addition to setting an agenda, we're going to jump into a behavioral chain analysis. And I'm guessing most people have at least heard of this before, but I think the big thing that we talk about in DBT is that this is punishing. It's not meant to be punishing. It's meant to be fun. So DBT clinicians need to work hard to make the BCA really fun in different ways. But here's what we're doing. We're looking at an incident that maybe was ineffective behaviors. You could look at one with effective behaviors as well. And we're going through as if it was a movie script from start to finish. What was the antecedent? What were the consequences? What were the vulnerabilities? What were all the steps that happened until whenever you want to stop the behavioral chain analysis. And we're really looking at every single piece of what were the thoughts, what were the feelings, what was the behaviors at that stage. And then the magic happens with the solution analysis, where we begin to pick this apart and say, okay, right here, we could have used this skill, or right there, you could have used that skill. And that's really where folks can learn it. And just putting another plug in for telephone coaching, right? For phone coaching, if it happens in the real world, it's a lot easier to reinforce it than if it happens when we're doing the chain, and we still do chains. And then finally, it's a dance, a constant balance back and forth between validation and problem solving. If I'm meeting with somebody early on in the sessions and they're really dysregulated, I'm pouring on that validation thick. I'm still sprinkling in some nice problem solving or change. A few more slides here. When we're doing our individual therapy, we're splitting up in 3 different ways. Target 1, we're focusing on decreasing life-threatening behaviors. All right, because without this, there is no therapy to be had. They might not be alive, or they might be in the emergency room, or they might be hospitalized, and I can't do the therapy. So this is what I'm focusing on first and foremost, regardless of what anybody, including the patient, wants me to focus on. And that means I need to be very validating to get them to talk about this first and reinforce when they're being effective, so these behaviors are decreasing. The next thing I'm talking about are therapy interfering, showing up late, putting their head on the table in the Zoom call, not engaging, not talking, maybe not telling me the truth, missing sessions completely, missing group. Without the treatment, then I can't actually do it. So I need to make sure that they're engaging in the treatment as well. And then the last piece is the target 3 stuff, which is the fun stuff. This is decreasing quality of life behavior. These are issues with anxiety related to going to school refusing behaviors, substance use behaviors. This could be kind of any of those kind of things that really bring folks to therapy that wouldn't fall in target 1 or 2. And this slide I really like because it allows me to bring it back to the basics. And when I'm doing supervision with folks, sometimes we'll look at the slide, or sometimes we'll say, hey, Zach, let's go look at that slide again. What I really like about it is it really helps you understand, depending on where a problem area falls, we know what skills to use. So if there's confusion about self, I don't know what my goals are, what my values are, where I want to be, who I want to hang out with, how I want to spend my time. Let's go into mindfulness. Let's bring up our awareness to what's going on in the moment. If we're struggling with impulsivity, self-harm, suicidal behavior, substance use, distress tolerance, which is getting through a difficult moment without making it worse. If we have emotional instability, we're going to focus on emotion regulation skills, which is thinking about decreasing vulnerability and increasing resilience. If we have interpersonal issues, let's talk about the interpersonal effectiveness skills, building and maintaining relationships, asking for what you want, setting limits in relationships. And then the last one, walking the middle path, that skill, it really has started with teenage and family dilemmas, and it's been brought into using dialectics and validation effectively. So this can be a nice guide in where those individual sessions are going to go, depending on where we are with the targets in the treatment. And my final slide is kind of this really well-known slide. It's so old, I couldn't find it on the internet, and I had to kind of take a photo and then put it in from my training that I did a long time ago with BTech. But this really highlights the dance that I'm constantly doing. It doesn't matter if it's session 1 or if it's 12 months into the work. It's a constant dance between change and acceptance. Maybe some irreverence if we're struggling to change, and maybe some reciprocal communication or validation with that acceptance, some problem solving as well. And it balances on the core skills of mindfulness. Sometimes I'm consulting to the patient and really working hard with them. Sometimes, even with my young adults, I'm going to consult to the environment, right? Probably not going to call workup, but this might mean we need to have a family session, and certainly with my teens. And then it all obviously balances as well on the team consultation that you have. So with that, I'm going to welcome my colleague, Beth, and so excited to hear her thoughts.
Thank you so much to my colleague, Dr. Zachary Blumkin, for that wonderful overview of how DBT approaches an individual struggling with severe emotion dysregulation and destructive behaviors. And thank you also to Dr. Jeffrey Miller for having us here today and for that wonderful introduction. Zach described the main tenets of comprehensive DBT, the setting clear behaviorally defined goals, the prioritizing of reducing life-threatening behaviors, the teaching of DBT skills, also the whole idea of drawing out the skillful behaviors and reinforcing them and extinguishing and not reinforcing the unskillful behaviors, which is a really important, very behavioral social learning approach that DBT takes, and the overarching dialectic approach of balancing validation and change. So I would like to just point out that these are the things that make DBT work for a very difficult to treat population. We know we have the evidence base that Zach also alluded to. What we don't talk about so much is, I think you can tell from his presentation that this is not easy work to do. And in addition to having all of these techniques and strategies and skills, we also need to figure out how to keep engaged in the treatment. DBT, I want to talk more about how DBT treats the clinician. And that includes actually drawing out skillful behaviors in the clinician and extinguishing unskillful behaviors in the clinician. We know that individuals presenting with the types of dysregulation that are symptomatic of borderline personality disorder, they often drop out of treatment. They're very difficult to engage. Or they are also often unilaterally terminated by burnt out therapists. So all of the great techniques that DBT has to offer are useless if the clinician and the patient can't stay engaged. And that's why we named this presentation Keeping Calm and Carrying On, because that really needs to happen in order to do all the rest of the work that Zach just described. I was one of the original findings from Linehan's original RCT, in addition to the DBT group having significantly reduced suicidal behaviors and hospitalizations, is that the individuals in the DBT treatment group were more likely to stay in treatment than the people in the treatment as usual group. And so this dovetails with an experience I had. I was very fortunate at the beginning of my career here at PI to work under the leadership of Dr. John Mann and Barbara Stanley in the Mind Division, where we went to Seattle to train, Barbara Stanley and I, to train with Marsha Linehan, and we came back and started to do clinical trials here in DBT. And when I was first a research scientist with Dr. Mann's group, I was interviewing the research participants that came through our clinical trials and was very struck by a comment from one of the research participants who had a long history of suicidal behavior and treatment. And she said, "Oh yeah, I was in DBT therapy. I'm not sure how much it helped me, but my therapist felt much better." And that still sticks with me because it really impacted me. I was just learning DBT myself, and I was thinking, well, hopefully DBT would have helped her, and maybe it did help keep her alive. Who knows? But more important, any treatment that helps a clinician feel better about treating chronically suicidal and self-harming individuals with borderline symptomatology, that's not a small feat. So why don't we take a look at how DBT helps the clinician feel better, okay? We know that DBT was originally developed to treat suicidal and self-harm behaviors in people diagnosed with borderline personality disorder. And most of the evidence base is still in that clinical population, although it has been expanded to other populations like eating disorders, substance use, adolescents, and teens. And we know that BPD is challenging to treat. And DBT is a very demanding treatment. I mean, Marcia can say it's very simple in a nutshell, but I think Zach gave us an idea of how much work it takes on the part of the clinician and on the part of the patient. It requires a lot of distress tolerance. And as much as Zach loves phone coaching, and I do too, and we can talk more about how it's very reinforcing for the clinician, it is also an extra demand to be available, to take a call in the middle of whatever you're doing and be confronted with somebody's distress. And finally, that staying on course and being very structured takes a lot of effort on the part of the clinician. It's very tempting to put out the fire of the week and forget about the life worth living goals, right? So we have to really always keep those life worth living goals in mind when we're trying to put out the fires of the crisis of the week. The life worth living goal is so important. I think there's also a misconception that we're just trying to reduce suicidal and self-harm behaviors, but we can't do that without building a life worth living. We're not trying to keep people alive to stay suffering. That's not the point. When Barbara Stanley and I had developed the clinical trials, she was the PI, and I was very fortunate to be a part of that enterprise. We started running clinical trials here to compare DBT with other forms of psychotherapy and with medications in order to see how effective it was in reducing suicidal behavior. And clinicians and colleagues and trainees started coming to us for consultation. And so we came up with a non-inclusive list of concerns that people brought to us, such as how do you deal with the chronic suicidality and suicidal communications, the needy, overly dependent, attention-seeking behaviors, and my personal favorite, the overly help-seeking and at the same time help-rejecting behaviors. They present with interpersonal hostility. They present with intense affect. They induce really difficult feelings in us. And we use the terms, well, DBT practitioners are taught not to use these terms, but it's very common to use the terms provocative, manipulative, which are not just non-judgmental descriptive terms. I think they really speak to the intense distress that we experience when we're treating these individuals at times. We expect them to be disrespectful of therapeutic and sometimes personal boundaries. We find them very difficult to engage and retain in treatment, and we don't see them getting better. So these are real challenges that are presented by this clinical population. I also want to make the claim that, unfortunately, as clinicians, when we're not trained in what we call a borderline specific psychotherapy, we're in danger of exacerbating these challenges. There's a transaction between the therapeutic approach as usual and the nature of the disorder that can iatrogenically exacerbate the challenges. We enter into treatments with these individuals with preconceived ideas that they're not treatable and that they're going to be difficult right off the bat. I was also very privileged to be a student of Dr. Herbert Schlesinger, may his memory be a blessing. And I remember being in his class, and he warned us not to apply the concept of the Procrustean bed when we're conducting clinical therapy. And so I knew that this concept had stuck with me all these years. And he wasn't a DBT trained therapist, but he was very open to doing what works with people. And so I looked up the definition of the Procrustean bed because I felt it very much related to the point I'm trying to make here, which is an arbitrary standard, especially one that is forced upon people for the sake of conformity and involves the sacrifice of what is useful. And so I believe that applying treatment as usual is applying the Procrustean bed at times, and that when we do that with every individual that comes for treatment, it leads to an erroneous assumption that the individual is not treatable if they do not respond. And so I'd like to argue and point out how DBT provides guidance for us as clinicians to refrain from exacerbating the challenges that these patients bring in, so that we can have a much smoother treatment that has traction towards meeting life worth living goals. And it didn't start with Marshall Linehan, actually, the ideas of modifying psychotherapy as usual. It actually was first appeared in the literature, at least from my understanding, in 1938, when psychoanalyst Adolf Stern was noticing, and he wrote 2 articles in the Psychoanalytic Quarterly that year. He was observing that there's a certain set of patients that he was experiencing having trouble tolerating psychoanalysis. He called that group the borderline group. And he said, you know, at the time, psychoanalysis was the treatment of choice. And so he said it's very important to try to get these people ready so that they're able to make use of psychoanalysis. So he made some modifications in his clinical approach, which meant having a more reality-determined relationship. What does that mean exactly? Well, he described having people sitting up and not laying on the couch and having direct eye-to-eye contact. He didn't allow for extended silences, which were very hard for these individuals to tolerate. A lot of paranoid ideation would crop up in these instances. He put less emphasis on transference interpretations and more on explicit support and sustenance. And I was thinking about this last night, and I was reminded that I think what he was saying is, I'm going to let therapeutic neutrality kind of go by the wayside here, because I think a lot of what we're talking about here is being a real person in the room with the patient. And that therapeutic neutrality is crucial when you're working in a transference psychoanalytic, psychodynamic frame. You need to have that. But that is the piece that I think is the most difficult for these individuals, that they need a more reality-determined relationship. They need the therapist to be a little bit more real and present as a person in the room. So DBT incorporates a lot of these modifications, and so do the other BPD-specific psychotherapies that have arisen in the last couple of decades, such as transference-focused psychotherapy, mentalization therapy, schema focus, and cognitive therapy for personality disorders. They all incorporate aspects of this modified approach that Stern originally suggested. And I think I would say even with transference-focused psychotherapy, there's less emphasis on the transference interpretations, and there's a little bit more reality-determined interaction going on in the therapeutic room. So to go back to how DBT incorporates some of these modifications, you've heard a lot about validation from Zach. It is a main bias in DBT. And I think we all probably feel as trained mental health clinicians that we all know how to be validating, and we all know how, and we do it all the time. And I would say that that's true. And I would also say that DBT puts a much more explicit emphasis on validation than other forms of psychotherapy. And it's not a natural response in the face of suicidal behavior, suicidal communications, dangerous behaviors, hostile interactions. It's not your immediate response to be validating. It's like, whoa, wait a minute, that seems very distorted to me. I didn't say that. I didn't mean that. That's really what you want to say. So it takes, I kind of think it's akin to martial arts training. Like, to be a black belt in karate is to, instead of push forward, but push back when you're getting that kind of thing coming at you, it's to move back and go with the energy of the person a little bit more. And that can make all the difference in lowering the arousal the way Zach was describing, so that instead of escalating the crisis and the hostility and the dysregulation, there's a calming effect. So DBT clinicians are trained to understand validation at 6 different levels. And I'm not going to go through them all in the interest of time, but I want to focus on level 5 and 6, because I think these are unique to the borderline personality disorder types of psychotherapies that put neutrality to the wayside and have the therapist, have a more real response in the moment. So level 5 talks about normalization. A DBT therapist is encouraged to say, hey, I would feel the same way in that situation, or that makes total sense to me. I think anybody would feel that same way in that situation. That's not something I learned when I was being taught psychodynamic approach. That's not neutral. That's taking a stand. We also have a level 6 validation, which has to do with believing in the patient, which is to say, I believe in you. And also to be radically genuine, which means I believe that you can do better. And so these are things that are not neutral. These are taking a strong stance. And I think that's a big part of the DBT type of validation that makes it unique in that regard. At the same time, when we're busy validating, we have to really make sure to not validate what's not valid. And that can be a very tricky dance as well. So what does it look like? Just some examples from clinical experience. People coming in with self-harm, suicidal behaviors. Again, we get so anxious about making sure that we try to control and reduce and make the person safe right away. And so we have all these great evidence-based interventions, the CSSRS, the safety plan intervention. We want to just make sure we're giving the person a safety and a safety net. That's great, and that's so important. And we also have to understand, wow, you must be really miserable. And this might be the only way you know how to make yourself feel better when you're experiencing unbearable distress. Or I guess these behaviors really do work for you to relieve distress in the moment. And also it actually gets you the help that you need. So I get that, right? When people are shutting down, when their heads are going down and they're not engaging, how do you validate that? You want to just shake them and say, come on, look at me. Let's talk. Let's do this. But you say, wow, you know, what I'm asking you to do is really hard. It's really hard to come to therapy, to get in touch with how you're feeling, to experience your emotions. And the shutting down kind of works, you know, it makes you feel better in the moment. And I get that too. How do I validate help rejecting behaviors, which is my pet peeve? That's this thing that really makes it harder for me to stay engaged with somebody who is asking me for help. Please, please help me. Oh, no, that's not going to work. No, you don't understand me. I have to try to understand that they have no reason to believe that they can get better based on their history and treatment. And I also have to hold out hope that I believe that they can get better. So I don't want to validate their hopelessness. I want to cheerlead to a level 6. I believe in you and I believe in the treatment. And what we can't validate is self-harm behaviors and other life-threatening behaviors that really don't work for them. So we can understand all the distress that leads to the self-harm behaviors, but we cannot agree that that means it's okay for you to engage in those behaviors. So that's an example of how the validation works and how we separate and the dialectic between what's valid and what's not valid. DBT also provides the clinician with clear protocols for managing self-harm and suicidal behaviors. You know, before I learned DBT, I knew how to assess risk and say, do you have intent? Do you have a plan? Can you act, or do you feel like you're going to act on it? If no, great. If yes, hospitalize. And if you have these thoughts, can you promise me, let's have a contract that you won't engage in these until the next time I see you? That was all I had. That doesn't really help with ongoing chronic self-harm and suicidality. So DBT provides more tools for the clinician to maintain to keep calm and carry on. We start with a motivational interviewing commitment phase where we reach a collaborative decision with the patient to make reducing life-threatening behaviors the #1 goal. It has to be collaborative. I think DBT was one of the first, and I don't know if Marsha Linehan meant it intentionally, but I think it's one of the first trauma-informed approaches that I have seen, because it talks about transparency, collaboration, providing safety, and trust. And so the collaborative piece is so important. And then you saw some of the tools that we use to diary card to track daily suicidal ideation, self-harm and behaviors, to teach skills for coping, and to target the suicidal behaviors with behavioral chain and intervention. And also the protocol for phone coaching. That's another part of managing. And that's one of the reasons why we love phone coaching, is because when you're working with suicidal individuals, if you know that they're going to call you for coaching, that relieves a lot of the tension right there, as opposed to they leave your office and a week later, they've been through so many ups and downs with their emotional reactivity, and the urges come and go really quickly, and the impulsivity, and you don't know what the heck is going on. It makes you much calmer as a clinician to say, okay, we have this relationship and we have this agreement, and that they're going to call me if there's a problem. DBT also provides a clear protocol for addressing therapy interfering behaviors, as that hierarchy of goals that Zach pointed out. If you don't have a patient alive, you don't have a treatment. And if you don't have the therapy going well, you don't have a treatment. So we prioritize targeting therapy interfering behaviors when they occur. And I know that Zach mentioned all of the ways in which therapy interfering behaviors occur on the part of the patient, but DBT also acknowledges that therapy interfering behaviors can definitely happen on the part of the clinician. Clinicians usually make one of the two following errors. I mean, they can make many errors, but being overly focused on change can be invalidating, and that can push a patient away and increase the arousal and disrupt the flow of this treatment. Or conversely, the therapist can be overly validating. I think some of the seasoned DBT clinicians fall into that category. We've seen a lot, and we're willing to tolerate quite a lot. And we say that makes sense, it's valid. But then we forget that, well, maybe we should be trying to expect a little bit more from our patients. And so it's really important to stay on top of the way in which the clinician needs to be pulling out those more effective behaviors and decreasing the unskillful therapeutic interventions that disrupt the treatment. And also the phone coaching, in addition to having skills coaching be a part of the phone contact, between session contact is encouraged if there's any kind of disruption in the therapeutic relationship. If my patient leaves the office and I feel that I was maybe being invalidating or pushing too hard for change, I should call and say, you know what, that was a tough session. I'm wondering if maybe I was pushing too hard for change and I wasn't listening to you well enough. Or if the patient leaves and says, I think my therapist is mad at me because I was kind of hostile and help rejecting, they're supposed to call and say, I want to repair this. We don't want it to wait a whole week until the next time we see each other, because that's one of the reasons that I think there's such a high dropout rate in this population, that these kinds of ruptures happen and then the person doesn't show up anymore. So it's built into the treatment to guard the therapy and to make sure to keep the relationship going and to make repairs when necessary. How am I doing? Okay. 2 more slides, I think. DBT has the peer consultation team that Zach mentioned. Also, very important, all therapists practicing DBT, comprehensive DBT, are required to be part of such a team. All the hard work that we're talking about maintaining that dialectic stance, about being able to validate when all you want to do is just say, stop it. The team helps with that. The individual therapist was one-on-one with a very emotionally dysregulated person, and it's hard to keep perspective. But you go to your weekly team and the team points out, hey, look, they showed up. They actually did their homework. You didn't see that because you were worried about the other thing that happened. So the team really helps support the individual therapist in maintaining that dialectical balance between validation and change. The team helps the clinician to refrain from doing all the work. This is another very big therapy interfering thing that clinicians fall into, and seasoned clinicians do it. I do it. We want to help and we overextend ourselves, and we do it because out of good intentions. And then we start to really be resentful. And then we start to want to disengage. And so it is on us to prevent our burnout. But it's really hard to do that by ourselves. So our team is there to say, you are extending yourself way too much right now. You're going to have to figure out how to pull back. So in order to keep the treatment going and to prevent burnout, and that's on the clinician. The team also points out that change happens in very small increments. I mean, when we have somebody who's actively engaging in self-harm and they come in again and they harm themselves, it can get very demoralizing. However, if they harmed themselves, but they tried 5 different skills before they did it, instead of having the impulse and the action right away, that's the kind of thing that the team helps the clinician see. Look, they actually tried this skill, and this skill. That's different, okay? The more space that you put between the urge and the action, eventually you're going to be able to withhold from doing the action, that you're building in new behaviors, even if the ultimate outcome is still not the one that you want. We are trained to notice the positives. When I get a diary card at the beginning of a session and I see their self-harm, I also make sure to look at which skills the person used, because we have to look at both things together, not just have one self-harm episode wipe out all of the other positive, skillful behavior that's gone on all week. So these are the ways that DBT treats the clinician, gives the clinician, the ability to keep on and carry on. There's also mindfulness practice and maintaining a non-judgmental stance. There's learning how to measure the change in small increments, which I mentioned, and the focus on transparency and collaboration. It's really important to not do too much of the work and to overextend yourself. That's something that when I work with the residents in training, we try to really make sure to monitor, are you doing too much of the work? Because if you are doing too much of the work, we have to step back and reflect to the patient, hey, I seem to be care about this more than you do right now. What's going on with that? You don't want to be the only one doing the work. That leads to burnout. And so I'm just going to end with all of these concepts leave the DBT clinician approaching the patient with the following assumptions: that the patients are doing the best they can, they want to improve, and they need to do better, try harder, and be more motivated to change. They may have not caused their problems, but they have to solve them anyway. To remember that their lives are unbearable as they are currently being lived, and that they must learn new behavior in all relevant contexts. What does that mean? It means that if you're in a really, really bad mood, you still have to figure out how to use your skills. In DBT, patients cannot fail in therapy. It's the treatment that fails. And last but not least, therapists treating patients with BPD need support. So I'm going to end on that, and then we can start with